Hi everyone, thank you for tuning in to our advocacy presentation, which is a collaboration between my placement at the Piedmont Athens Regional Community Care Clinic and Camilla's placement at Project Safe.
Okay, so I'm placed at Project Safe. That's a nonprofit that's working to end domestic violence, and it serves individuals affected by domestic violence. And I am a direct services intern, so that means that I can operate the statewide 24/7 text line. I help out with documentation. I shadow advocates at the shelter and at the Family Protection Center, and I help connect resources and other various tasks. So what is IPV, intimate partner violence? That is physical, verbal, emotional, economic, and or sexual abuse perpetrated by a partner in an intimate relationship against another partner. Although formally defined as domestic violence, IPV is more inclusive of abusive relationships that occur both inside and outside one's home.
So I have been placed at the Piedmont Athens Regional Community Care Clinic this year for my practicum, and this is a primary care clinic that serves many uninsured patients. It is not common for primary care clinics to actually have social workers on staff, but my supervisor, Lisa, does a lot of work there that I've been assisting her with, which includes handing out resources to patients as they need, assisting with referrals, education on financial assistance applications and other options, and much more. What's interesting about this clinic is that it's overwhelmingly made up of resident physicians, meaning those who have graduated from medical school but are still in training.
So the need for collaboration. The PCCC primarily serves uninsured and low-income patients, which means higher risk for IPV, and the PCCC's doctors are primarily made up of residents who are still learning and do not understand the prevalence of IPV or the signs.
So, based on that, for our advocacy project, we made 2 flyers to be used at the community care clinic in partnership with Project Safe. The first flyer is an informational flyer about IPV. So this flyer includes information such as the definition of IPV, how doctors can spot warning signs for victims and perpetrators of IPV, and information about Project Safe. The second flyer is an assistance flyer for those who might be victims of IPV. This flyer also contains information about what IPV is, as well as how to receive help, services that Project Safe offers, and tear off number tabs for Project Safe's 24-hour crisis hotline. We did this intentionally so that if a victim of IPV were to take a number and their partner found it, then they would not know it's for a domestic violence hotline, especially since Project Safe's hotline workers are trained to answer the phone and make it seem like they're not an IPV domestic violence hotline.
So with the informational flyer, we distribute that in the doctor preceptor rooms and in common staff spaces because it is geared towards towards staff members. And the assistance flyer has been placed in the social work offices in hopes that it can connect to those who are experiencing IPV.
So in terms of the process of this project, we started out by determining any educational needs at the clinic and other healthcare settings. And after talking with my supervisor and Camilla, we all decided that this is an important subject that needs to be addressed more in primary care settings. Next, Camilla collected and organized information about IPV education, awareness, and assistance. Then I used the information Camilla provided to design the flyers that you just saw. I did this in consultation with healthcare and social work professionals to make sure the information was easily digestible for both the resident doctors and patients. Next, we had to seek approval for the placement of the flyers in appropriate areas, and we'll talk more about this in the barriers to implementation section. And then once the flyer was approved, I announced the creation of the flyers and the purpose of having them in rounds to all the residents at the clinic. It was surprising that many of them did not know what IPV was or domestic violence, which is what it was formerly known as, or how to spot the signs. So this was encouraging that our advocacy efforts might help. And finally, I placed the flyers in appropriate areas designated by management, which ended up being in the doctor preceptor rooms, like Camilla said, which is where the doctors chart and discuss patients, other public staff areas, and the social work office.
Achieved outcomes. So one of our achieved outcomes is that we were able to provide education of intimate partner violence to doctors and staff in medical settings, such as what IPV is, what warning signs are for victims and perpetrators, risk factors, who can be contacted if they suspect that IPV is occurring and other things like that. We were also able to organize discrete resources for victims of intimate partner violence and how to best get the information to them, such as our unlabeled 24-hour hotline number tabs that we attached to those flyers, and also just increased awareness of intimate partner violence overall.
Yes, so in terms of barriers to implementation, the first hurdle we needed to jump was the placement of the flyers. So management at the clinic wanted to cut down on the amount of paper in public restrooms and in hallways, which really limited our ability to place the flyers for discrete patient access. Unfortunately, there was really no way to resolve this considering the manager of the clinic decided. So we had to put the assistance flyer both on the door and inside the social work office only. The next barrier is kind of related in that we had concerns for victims in terms of where we place the assistance flyers. If we put up too many flyers, then if we put too many of the assistance flyers, then there would be the possibility that a perpetrator could see, take note of the number or appearance of the tabs, and then the victims could be put in further danger. So this again was resolved by only placing the assistance flyers on the door and in the social work office. And then our last barrier was concern about the amount of flyers already placed in the preceptor rooms. Since there are already many pieces of paper hanging on the walls in these rooms, we were a little worried they might go unnoticed, but we resolved this issue by continuing to make announcements at rounds about the flyers.
So critical thinking, we have come up with a couple of questions. Our first one is, how difficult do you think it is to provide victims of intimate partner violence with safe, reliable resources to help them? Do you agree with the PCCC's decision not to place flyers in the bathrooms?
And then our second critical thinking question is, when completing this project, very few doctors knew about the warning signs of intimate partner violence. Does this shock you? And if so, how do you think we as social workers can help improve the education of social issues in the medical field? And that is it. Thank you guys for tuning in, and we look forward to discussing those questions with you.